Art Optical, AVT, Bausch & Lomb Specialty Vision Products, Blanchard Contact Lenses, for our platinum sponsors, we have AccuLens, Alden Optical, Contomac Materials, Esclera, Menicon, OptiView, Paragon Vision Sciences, Trueform Optics, Visionary Optics, and Excel Specialty Contacts. And then we would also like to thank our silver and bronze sponsors for all of their support, again, making these webinars possible, making the Scleral Lens Society possible, and all the information that brings along with it. So at this point, I'm going to go ahead and give a quick biography on the two presenters tonight. We'll be presenting on modern scleral lenses, and then I'll turn it over to them. So first up, we have Dr. Melissa Barnett. She's a principal optometrist at the UC Davis Center in Sacramento. She's an internationally recognized key opinion leader specializing in anterior segment disease and specialty contact lenses. Dr. Barnett lectures and publishes extensively on topics including dry eye, anterior segment disease, contact lenses, and creating a healthy balance between work and home life for women in optometry. She's a fellow of the American Academy of Optometry, a diplomat of the American Board of Certification in Medical Optometry, and serves on the board of the American Optometric Association, the Cornea and Contact Lens Council, Women of Optometry, Gasper Lens Institute, Ocular Surface Society of Optometry, and she is the immediate past president of the Scleral Lens Education Society. Dr. Barnett is a spokesman or spokesperson for the California Optometric Association and is a guest lecturer for the Staple Program. She was awarded the Thea Award for Excellence for Mentoring by Women in Optometry in 2016. In her spare time, she enjoys cooking, yoga, hiking, and spending time with her family, Todd Erickson, who is also an optometrist, and her two sons, Alex and Drew. Our second presenter is Dr. Pam Satjawatcharaphong. She received her optometry degree from the University of California, Berkeley School of Optometry in 2011. The following year, she completed a residency program in cornea and contact lenses at the Southern California College of Optometry. She's a fellow of the American Academy of Optometry and of the Scleral Lens Education Society. Her interests are in specialty contact lens fitting for irregular corneas, challenging refractive errors, disfigured eyes, and the treatment of ocular surface disease. Pam is currently an assistant clinical professor at UC Berkeley, and is also the chief mentor for the cornea and contact lens resident. She currently teaches third and fourth year optometry students in primary care and contact lens clinic, and is a guest lecturer for the second year contact lens course. She also performs clinical research in the ocular surface imaging clinic, focused primarily on managing meibomian gland dysfunction. When she's not in clinic, she enjoys traveling to far-off destinations, fine dining, and playing with her dogs. And with that, I'm going to turn it over to Dr. Barnett.
Well, thank you so much for the kind introduction, and thank you all for joining us tonight and taking valuable time out of your busy schedules to learn about scleral lenses. So this is a fun lecture that Pam and I are doing together. So we're talking about scleral lenses for the management of ocular surface disease. We're going to go over materials, lens treatment options, solutions and handling, the prevalence and risk factors for dry eye, and dry eye evaluation and treatment. When I lecture about scleral lenses, I often get questions about dry eye and the surface of lenses and the complications of scleral lenses. So hopefully we'll be able to answer some questions about scleral lenses and help you in your practice and help with your patients as well. So scleral lenses for ocular surface disease, the concept has been around for quite a long time. And the thought was it can rehydrate the cornea, protect the ocular surface. You can see the bottom right here. This is a picture of a persistent epithelial defect. This was a patient of mine who was a soft contact lens wearer, and she had this epithelial defect that would not heal after an infection due to her soft contact lens wear. So she was sent to me. We used topical antibiotics along with the scleral lens. Her defect healed up, and here you can visualize an image of a corneal scar. Fortunately for that patient, she was 20/40, even with that dense corneal scar that you can visualize. There are many different conditions where we use scleral lenses for ocular surface disease. In patients who have mild or moderate dry eye and don't have any systemic disease, scleral lenses are a great solution, even for those patients with healthy eyes and normal refractive error with dry eye. In my practice, I see a lot of patients with Sjogren's syndrome. I have a special interest in Sjogren's and dry eye, and scleral lenses are just wonderful for those patients. It's so gratifying to put the lens on, and patients with Sjogren's say, oh, it feels so great. My eyes feel so wonderful. I had an amazing patient last week, a story where the corneal specialist came to me after it just in follow-up. The patient was following up with her, and she said, did you know that you changed her life fitting her with scleral lenses? And I said, oh, well, that's wonderful. That's great, but I think that's what we all do, is we can utilize this technology to change our patients' lives and make them better. And in my clinic, we also have patients with severe dry eye due to chronic graft versus host disease, Stevens-Johnson syndrome. Limbal stem cell deficiency is actually one of my favorites for scleral lenses because it's so helpful to correct the limbal stem cells, to rehabilitate the ocular surface, and to provide a nice, smooth front surface on the cornea. For those patients with exposure due to anything, corneal palsies or leg ophthalmos, scleral lenses are beneficial, and including those patients who've had a history of trauma. So I'm not going to read every single research study that's ever been done on scleral lenses for ocular surface disease, but here you can see there's an overview. And the point being is that scleral lenses have been around for a long time. In the published literature, as early as 1943, we can see that scleral lenses were used for the management of exposure in neuropathic keratitis, and throughout the years, there have been multiple publications about scleral lenses used for ocular surface disease. So in some practices, the main indication of scleral lens use is for ocular surface disease, whereas in other practices, the main indication is corneal irregularity, such as keratoconus, or those who have had a penetrating keratoplasty or any sort of post-refractive ectasia. And in my practice, I think along with a lot of others, I have a wide combination of indications for the use of scleral lenses, but they're just so amazing that they can do such a wide variety of things. So I'm going to just give you a quick update on the literature of what's been out there recently. So this came out in 2015. It was a study looking at scleral lens use in dry eye syndrome. And this was just a review study that reviewed the evidence of scleral lenses and the use in dry eye. So the study determined that scleral lenses are very well tolerated. They definitely help dry eye syndrome, and more research is needed to compare different sizes, types of lenses, and to standardize outcome measures. I'll pause here and state that much research is needed in general for scleral lenses. There's so much we don't know about the use of scleral lens. For long term, it would be wonderful to have 50-year or 100-year research about scleral lenses on eyes, but we don't have that. And there are so many aspects of scleral lens technology that we still need to research at this point in time. The next study is looking at a scleral lens in moderate to severe dry eye. This came out in 2016. Looked at 41 eyes from 25 patients with moderate to severe dry eye. And before before and after scleral lens treatment, looking at visual acuity, osmolarity, Schirmer's tear breakup time, corneal and conjunctival staining, meibomian gland grading, OSDI. And this was baseline compared to 12 months of scleral lens wear. This study indicated there was an improvement in vision, there was a decrease in tear osmolarity, and improvement in dry eye symptoms, and improvement in quality of life, as studied by the OSDI. And we know that there are many quality of life studies out there that show that dry eye significantly negatively affects quality of life, and this study indicates that scleral lenses can be used to improve quality of life. So the next study is looking at conjunctival impression cytology, and I always joke that if you don't like your patient, then you can do impression cytology. It's not very comfortable. And this looks at patients with dry eye using scleral lenses, and this was from 2017. This was 41 eyes of 25 patients with different conditions, including Stevens-Johnson, Sjogren's, GVHD, and undifferentiated dry eye. And impression cytology was obtained at baseline and then after wearing scleral lenses for 12 months. The impression cytology score, interestingly enough, did not differ significantly before and after wearing the scleral lenses for 12 months, but the HLA-DR antigen in the temporal conjunctiva after wearing scleral lenses for 12 months significantly increased in patients with Sjogren's syndrome. And we're going to talk about that a little bit later in this presentation. A different study is looking at PROSE treatment for exposure keratopathy. This was from 2016. A retrospective study was done of 18 patients. They were evaluated before and after treatment, OSDI, visual acuity, and corneal staining. There was an improvement in visual acuity from 2080 to 2035, improvement of OSDI, and decrease of corneal staining in this study. They concluded that PROSE therapy is an effective treatment for exposure keratopathy, and it can be an alternative to eyelid surgery. We're almost done with the studies, and then we'll get into all the fun stuff. This is looking at the short-term effect of scleral lenses on dry eye biomarkers and keratoconus, and this came out in 2016, evaluated the signs of dry eye before and after scleral lens wear for 8 hours, looking at factors including Schirmer's, MMP9, and osmolarity. And we often do see dry eye in patients with keratoconus. This study looked at 26 patients with keratoconus. There were no significant changes in Schirmer's and tear breakup time, but significantly improved OSDI. There was a significant lower osmolarity, higher MMP9 in this study. They also concluded that scleral lens wear improves the symptoms and some signs of dry eye, and thought that the increase of MMP9 may be caused by the tear film stagnation and use of preserved saline.
Okay, this is Pam here. I'm going to be starting out by talking about when we would use sclerals within our overall management strategy for dry eye. So like Melissa, I see patients for mixed reasons. I have patients who come in with keratoconus or post-surgical, but I also have a lot of patients who are coming in exclusively for dry eye. And I see patients for dry eye who currently aren't wearing any lenses at all. I do think that when possible, it is really important to try and manage whatever underlying cause of the dry eye might be there. So assessing what the systemic etiology is and kind of co-managing with other practitioners might be something that should be considered for patients with severe disease. But things that we can manage ourselves as optometrists certainly are lid inflammations like meibomitis, blepharitis, and Demodex. So it's a discussion that I have with my patients who are interested in sclerals, and we'll go into a little bit more detail about how we as ODs can manage that. I do think that sclerals can be used in conjunction with ocular surface disease management, particularly for protection and symptomatic relief. but because it's still a contact lens that's on the eye, and as Melissa mentioned, there is still a lot that we don't know about sclerals, it is important that we have a discussion with our patients regarding the risk versus benefits of using a scleral lens, particularly if you're doing it on a normal cornea. A lot of times for patients with keratoconus or irregular astigmatism, we can really argue for the benefit of vision being there that might outweigh the risk. But in some cases, we have to really have a candid discussion with those patients. So let's talk a little bit about material and treatment with regards to sclerals. So decay and wetting angle are properties of materials that we really want to look at when we're making a decision about what we're making our scleral lenses out of. So taking you guys back maybe to optometry school, maybe not, lower wetting angles usually have a less hydrophobic surface. So it improves surface wettability. As you guys can see in that bottom right photo, it spreads the fluid out more over the surface. And so this generally is going to be better for the maintaining of a clear lens surface. So the trend has been, in terms of thought, that higher decay GP materials tend to have a greater or higher wetting angle, but I don't really always find this to be the case. Each material in and of itself inherently has a decay and a wetting angle associated with it. So for instance, Boston XO2 has a higher decay than Boston XO, its counterpart, but it has a lower wetting angle. So it has both a higher decay and a lower wetting angle. So it's always good to kind of look up what those properties are for the particular material you might be interested in using. So just think about what suits your patient best. I think for the most part, most scleral lenses are plasma treated. This is a thin layer of hydrophilic molecules on the surface which decreases the wetting angle and thus improves the wettability. But it is very important to know that this treatment is not permanent. It comes off with daily handling, just even if the patient is doing everything appropriately. But there are certain abrasive cleaners or in-office polishing that can remove it prematurely. So it is important to educate patients about appropriate solutions, which we'll go into in a moment. And we do recommend alcohol-based cleaners rather than gritty cleaners. Something that has recently come out and has been FDA approved in the market is called Hydra-PEG by Tangible Science. It is in a sense, a permanent type plasma treatment. It encapsulates the lens with these polymers that really improve the wetting surface, and it can be applied to pretty much any GP lens, but there are only certain labs that are doing it currently. Hopefully more labs will pick it up so that a lab that you may work with would be able to offer this as an option. So there is a process that the lens goes through depending on the type of procedure the lens is made. You guys can kind of see generally it's either going to be lathe cut or molded, and so the procedure might be slightly different. But once the lenses are prepared and active, they can be soaked in these polymers, and these polymers will permanently bind to the lens, and that really results in optimal wettability, lubricity, anterior film stability, and resists to deposits. I myself have ordered some of these because I do have a lot of patients who are struggling with poor wettability, and I think Melissa also has had pretty positive results from her patients with this procedure as well. So with regards to solutions, as I mentioned before, we try to avoid abrasive cleaners. So the Boston Advanced and Boston Original cleaners do have kind of a silica bead component, which can be fairly abrasive and remove plasma treatment. So in general, I try and go as minimal as possible in terms of potential things that can stick on the lens or affect the lens. So I really do like peroxide. So Clear Care is one of the ones that I will recommend to a lot of patients. Most of the time, the actual Clear Care case can accommodate a pretty decent sized lens, I'd say 16 or so millimeter diameter. But if you have a lens larger than that, there is an option of purchasing a PROSE basket case, which is a larger case for Clear Care. Optimum is also a option. This solution is actually alcohol-based, so it doesn't affect the plasma treatment as Boston Advanced does. Boston Simplest and Unique pH are both multi-purpose solutions that can be used for sclerals as well. The one thing I will mention is that as of right now, if a person gets Hydra-PEG on their lenses, I believe only the peroxide and the unique pH are recommended for those particular lenses. I don't know if that will change in the future, but for right now, those are the two that Tangible Science is recommending to use. Okay, so with regards to additional cleaners or deposit removals that go beyond just your daily disinfecting and storage, we have down at the bottom photos of several different options. MiraFlow used to be on the market and it kind of was discontinued, and then a private OD actually picked up the formulation and restarted making it. It used to be marketed for soft lenses actually, and you can actually see in the description in the photo, it says it works for all soft lenses as well as hard contacts, but originally marketed for soft, and then we realized how well it worked for GPs. So this solution can be used to clean a lens and really do a really good job of cleaning off extra deposits. Similarly, Optimum Extra Strength Cleaner is an option, and Super Cleanse as well. These require kind of a manual rubbing and rinsing off of the cleaner. Medicon makes ProGent, which is a combination of two solutions that do a maximum 30-minute soak. This does a really good job of removing deposits as well. And in the past, it was really used for corneal GPs, but now you guys can see there's a scleral basket available because sclerals have become so much more popular with their, there are more and more practitioners fitting them.
Great review of all the solutions, Pam, and yes, I've had very positive experience with Tangible Hydra-PEG. It's been a definite help for all my severe dry eye patients and Sjogren's patients as well. So what are the solutions out there for application? So we definitely want something that's preservative-free because we know that the solution is going to bathe the cornea all day long, and we don't want preservatives in the tear reservoir because they can cause a toxic reaction. So available solutions at this point, one is LacquerPure, which is FDA approved, and this is obtained from Medicon from the website, and they come in 5 ml vials. I will tell you it is important for all preservative-free solutions to recycle the solution after a single use and not to save it. I've had so many patients that have saved their solution because there may be a lot in that vial. But if the solution is saved, remember it doesn't have any preservatives and it can cause a toxic reaction. So that's something I learned after years to really ask every patient, make sure that you're disposing of it or recycling it after one use. Another option that's been around for a while is non-preserved inhalation or nebulizer solution. And I'll show you on the next slide how that's prescribed. Comes in those little pink vials. Scleral fill was just introduced, and that comes in a 10 ml vial that it can be obtained from the Bausch & Lomb Specialty Vision Product website. And again, that's 10 ml. PureLens, which comes in a bottle, comes in a 4-ounce bottle. It does contain buffers, and PureLens does need to be disposed of in 14 days. So if you are prescribing inhalation solution, which is not FDA approved, and this is an off-label use, it is preservative-free and buffer-free and comes in individual vials, the solution can be sent to a pharmacy, and the prescription and the way to write it is written down here. Use as directed with an ocular prosthetic device. In my area lately, they're asking how often, how many times a day. So if you are having your patients remove and reapply their scleral lens, you might want to say to use it 2 or 3 vials per day, depending on your patient. And alternatively, this solution can be obtained online from Amazon without a prescription. So it is important to verify with your patient that they are receiving the 0.9% solution versus a different percentage if they are obtaining it online. I've learned that I call the pharmacy and let them know if I'm prescribing this that it is correct, because if I don't, I'll either get a call back saying, is this really what you want? Do you really want nebulizer solution to use in a bowl of a scleral lens? Or worse, the person will just tell my patient to substitute with something different. And we've seen it all, and I'm sure Pam has, and everyone who's fit scleral lenses, a soft multi-purpose solution in the bowl of the lens, a gas permeable condition solution in the bowl of the lens, and we don't want any of those solutions. Again, we want them preservative-free. So some patients have really significant debris on the front surface of their lens, and so there are different methods that you can use. So one is the squeegee method. So you can take the DMV applicator, moisten it with a non-preserve solution or anything, not water, I guess I should say, and then just sort of turn it on its side and do a little squeegee method to clean the surface. If you don't have a surface coating, you can use a moistened cotton swab, again moist on the surface of the lens. Now where this comes in handy is sometimes when you're fitting a patient with diagnostic lenses, and if the lens is not wetting as well as you want it to wet, you can actually use this method as well. So you don't have to take the lens off at all. You can just use the squeegee method, clean up that front surface, do a quick over-refraction without taking the time to take the lens out, clean it, and put it back in. Now, other options that I use often are higher viscosity eye drops in the bowl of the lens to help with post-lens tear reservoir clouding. Celluvisc is one I use quite a bit, where I start with 2 drops of Celluvisc along with a non-preserved solution in the bowl of the lens, and that can help have increased viscosity. Now, sometimes I'll increase the amount of a higher viscosity drop as well, so maybe start with 2 and then go up to 3 or 4 until the vision gets blurry. If the vision gets blurry, I'll reduce it. Oasis tears is another option to use in the bowl of the lens. If a patient is using autologous serum drops, that can also be used in the bowl of the lens along with preservative-free saline. So there are all sorts of tricks. Sometimes it's a little bit of a trial and error to determine what sort of mixture is best for the patient. Hopefully in the future we will have additional solutions out there that have properties that can actually help with this reservoir clouding. Some patients need to actually physically remove their lens midday and reapply it in order to help with the front surface wetting issues, and I would say now compared to 10 years ago with the advancements in technology, they're so much better that my patients are not experiencing the fogging like they used to, so they don't have to remove and clean their lens as much as they used to before, and also with the surface treatments it's helped to prevent this as well. Now we do want to make sure that plungers are clean and not dirty. I love the idea of patients having the applicators everywhere. So if they're at home or at work or in the car or the gym, and making sure they're clean and not just in their pocket. I hate when that happens and they pull it out. Pam, I'm going to let you tell your story about, it's the best plunger story I think I've heard of, where you looked inside that plunger.
Yeah, so we had a patient who probably kept their plungers in kind of a moist plastic baggie, and it never really was dry, and stored it on its side, and he was having this issue with the surface not being, you know, that great. So I was kind of just looking at the plunger, and I kind of peeked in, and there was mold growing inside it. It was pretty disgusting. So, you know, I always talk to patients about if they're going to clean their plungers to make sure that it gets dried out on the inside as well. So, well, or just replace it really a little bit more frequently.
Thank you. That's a great story. It is really important to replace, just like we replace contact lens cases, if we're using peroxide solution, to replace the case every single time new solution is purchased. It's so important to replace the plungers and replace the applicators regularly. And some people recommend quarterly. I would actually say more often, just to be safe, and it can really affect the front surface of a lens. Now, talking to our patient about eyelid hygiene and hand hygiene is also quite important. So we want to make sure that our patients are washing their hands before handling contact lenses in general, especially scleral lenses. I like to ask my patients about what sort of hand soap they're using and make sure that they're using mild or basic hand soaps or contact lens specific hand soaps or acne treatment hand soaps, and nothing that is oily or greasy at all. And it's also important to ask patients about their face and eye creams and making sure that they're applying face and eye creams and makeup after the scleral lenses are put in, not before. So it's very important not to use oil-based moisturizers on the eyelids. Really important, and this goes for all contact lenses, not to apply makeup to the inside area of the eyelid margin that could just get on the contact lens. It's probably important just in general not to apply any makeup on the inside area of the eyelid margin, and reviewing different sorts of creams and makeups. And I find that my patients ask me for recommendations, and I have a whole list of things that I like to talk to them about, because patients really do want to use healthy options that are good for them. And I find that as their eye care provider, it's a good, talking relationship, and I can have, product recommendations out there, just like we recommend anything, treatments to clean eyelids. There's so many artificial tears, you could say, or medications. Creams and makeup are now another topic that we can really talk about and help our patients. And of course, it's really important to stress follow-up, to come back and review not only the lens fit and vision, but also the condition and the health of the eye. So not only the cornea, but the conjunctiva, the lids and lashes, and everything else as well.
So I'd like to go over a patient case that kind of exemplifies some of the things that we just discussed. So this patient was a 44-year-old Asian male, and he presented with Graves' ophthalmopathy and chronic corneal exposure. He was referred to us from an ophthalmologist who, as you guys can see, had already performed a tarsorrhaphy of the right eye. And it's not so pretty, but it did cover the cornea better than he was doing previously. And his left eye had not had a tarsorrhaphy, but he did have a cataract extraction in that eye. He has type 2 diabetes, cardiac irregularities, and is a current smoker. He was referred for a scleral fitting of the left eye only, but as you can see, at some point during the fitting, the tarsorrhaphy failed and he had a breakage of the sutures, and both eyes were pretty unhappy and exposed. So his entering VA when we saw him was light perception in the right eye, and this is due to the chronic exposure and opacification of the cornea, and he was counting fingers at 6 inches of the left eye. We did fit the left eye only with the scleral, and we achieved a best corrected VA of 2100, and he did report much improved comfort. But despite the scleral lens being there, he did still struggle with significant lens deposition throughout the day. And this is because even though the lens is there, he still had an inability to blink due to his condition. So we ended up doing multiple things for this patient. There wasn't just one solution. So we did recommend Clear Care for regular daily disinfection. We did have him use Miraflow daily for deposit removal. He was using an erythromycin ointment, and he didn't tell us this until later, but that actually was likely contributing to the gunk that was getting on the surface of the lens. So we actually had him discontinue using that while he had the lens on, and we let his ophthalmologist know that we were going to do that as well. He did perform the squeegee method while the lens was on with the small DMV plunger as needed, so that way he didn't have to remove the lens to clean it. And most of his problem was actually occurring on the surface rather than on the inside of the lens where the tear reservoir was. and we did continue co-management with the ophthalmologist. So he was reporting quite an improvement in his quality of life. He was excited about being able to watch the Warriors, his favorite basketball team, on TV again. So, you know, this was his only seeing eye, and we actually gave him some functionality back. So we were pretty excited about that. We talked about fitting the other eye for comfort, but we left that up to the ophthalmologist. Okay, we can keep going. So I did want to mention there are different methods for application and removal. These stills were taken from the Scleral Lens Education Society instructional video, and this is something that I have all of my patients who are coming back in for application and removal training to watch and do a little homework, essentially, in preparation. So you can see we have a tripod method with the fingers, kind of 3 fingers together. Sometimes you can do 2 fingers, and then we have the large DMV cup inserter. In terms of removal, we recommend that small DMV plunger placed at the edge of the contact lens in order to release this suction. And again, there's the website that we refer patients to. Practitioners are also welcome to watch it, so you can kind of see what we are educating the patients on. And in some cases, you can also use the large DMV plunger or your hands for removal, but I find the majority of patients find the small DMV to be the best option.
And Pam, I'm also going to add in that we also share the video widely. So if you want to use it on your website, if you want to share it with patients, we share it with everyone. And the video is about 10 minutes long. And I as well have my patients watch the video prior to coming in for training. And it really saves a lot of time for my staff, which is wonderful.
Absolutely, yeah. So one of the most common problems during handling is lens bubbles. And this is almost always from insertion error. So there are a couple tips that we use to help patients make sure that their bubbles are not occurring. One being making sure the lens bowl is filled fully with the saline, and I usually have them fill it up all the way up to the top. It might be even doming over. I recently did a wet lab with my students, and there are a couple of them that were getting bubbles, and I saw they weren't filling the lens all the way. So we actually worked on that. Additionally, you can see you can even cut the bottom of the DMV plunger off and use the hole and the light through the hole as a guide for fixation, and that can often help prevent bubbles that occur from the patient moving their eye away or rolling it away, blinking at the last minute. Now keep in mind this actually then removes the suction ability of the plunger, so it's acting more as a pedestal. So there are some other specialized tools that we will use. The Sea Green lens inserter by Dalsy Adaptives is shown here. It has a plunger stand, which can also have a green LED light that helps with fixation. The stand will hold the plunger in place securely, and this can be helpful for patients who have unsteady hands or require both hands to pin the lids. So this is an example of a patient where they don't have all their digits available to hold the plunger and open their lids. I actually recently used this on a patient who had a congenital bone growth disorder, so he was not able to use his hand one hand to open his lids, so he needed to use both of them, and we used something like a pedestal here to help him successfully insert his lenses. So there's also the Easy Eye Scleral Lens Applicator, which is useful for one finger lens insertion. So you can kind of see, again, it acts as a pedestal and can be slipped onto the finger. And the website is there if you wanted to look into that. And if you want to kind of DIY this, you could also purchase one of these O-rings at a hardware store, which also can balance the scleral on there. This ring is put on the finger, and then the lens is put on top of the ring for stability. So we're going to move into a little bit of a discussion about dry eye and risk factors. I'm not going to read every single risk factor here, but you guys can see that there is a column for intrinsic risk factors and then a column for extrinsic risk factors. There are certainly things that we can't control, but there are some things that we can control. So we'll talk about modifications we make for our patients. So when I do a dry evaluation, this goes certainly beyond what most optometrists would do in a primary care exam setting, but there are a lot of things that we can do to help medically manage our patients with dry eye. I'm very much focused on eyelids and lashes. I look for meibomitis and blepharitis with slit lamp evaluation. I additionally will also do a expression of the meibomian glands, because a lot of times meibomitis is non-obvious. You might not see these really huge, like, membranous caps, which we might be used to seeing and identifying as meibomitis. Sometimes patients are so atrophied or so blocked up that nothing's really coming out even when I press. I also will sometimes perform meibography, which will allow me to image the glands. Demodex can also be viewed with slit lamp and sometimes microscope evaluation if that's available. And I recently went to a talk that talked about kind of twirling the lash with forceps, which also allowed better visibility of the mites. You can also use certain vital dyes like lissamine green to look for lid wiper, epitheliopathy, or conjunctival staining. And then I also can sometimes check to see if there is subtle lag ophthalmos with my transilluminator. That's where you kind of rest it against the closed eyelid to see if light is leaking out at the bottom. Obviously, we can easily test the cornea for staining with fluorescein. We can also check tear film stability or tear breakup time that way, look for tear film debris. Schirmer's or phenol red thread can be used to measure tear volume, and certain devices can be used to measure osmolarity of the tears. I try not to ignore the conjunctiva because a lot of our patients who have severe ocular surface disease also can't close their eye enough to cover the conj, and so you'll often see hyperemia or staining there as well. So again, we try to address the underlying dry eye as much as we can first to improve success with contact lens wear. Here's just some imaging of the different testing that I've done in office. So when we talk about dry eye, we know that there are different types of dry eye, different etiologies, but by far the most common is evaporative dry eye or meibomitis. I really do encourage you guys to kind of take a preventative stance on meibomitis. I really find that it's increasing in my opinion. I feel that younger and younger patients are getting it, and I think that it's something that can be prevented with proper management. You know, I do, like I mentioned, in-office expression and debridement, which can provide symptomatic relief and jumpstart a patient's home therapy. Kind of talk about it like we're doing the deep dental cleaning in office and you have to go home and brush and floss, so they have to go home and do their home therapy, like their compresses and scrubs. But we can kind of help jumpstart it. In terms of pure aqueous deficient dry eye, it definitely is the smallest subset of patients. So I do think that meibomitis is the one you guys will run into the most. So hopefully the video will work here. I just kind of wanted to show a picture, or a video, excuse me, of me expressing a patient with non-obvious MGD. So you guys will see kind of in the center the meibum that's coming out. That's a very obvious toothpaste sign. So when you first looked at this patient's lid, you know, it didn't look terrible. It actually looks pretty flat, doesn't have big caps, but they were very internally blocked there. So I'm just pushing very gently with a meibomian gland expressor, but you can use your finger and push a little harder. And then here in the other video, I'm just going to show a brief debridement. So I use kind of a golf spud-like tool, and I run it along the line of marks where the meibomian glands are housed. You can see there's some lissamine green there because I already did some lissamine green staining. And you might be able to see in the center as I'm pressing, some of the glands are expressing a little bit of thickened meibum. And then I use the tool and I just run it along the gland line and try and take off any caps or any blockages that I can. Okay. So I think meibography is a really wonderful thing that we can use to educate our patients. So sometimes patients don't realize that their glands have atrophied as much as they have. As you guys can see, the imaging on the left, there's pretty significant atrophy in the upper and the lower lids. The glands are shortened. In the right, there are still glands present, but they're starting to get atrophied, and you can see the tortuosity of those linear gland ducts is occurring, and that is often a precursor to them actually atrophying. So this is upper and lower lids. So I use this as a tool to educate my patients about, hey, you know, we want to prevent this from getting to the point where you are symptomatic. So it's something that you guys, if you have the technology, can do. But you can even do this grossly with a transilluminator against the lid, and you can actually see what glands might be there. It's just a little harder to show your patients. And in terms of treatment, there's definitely room for a lot of different options besides scleral lenses. Obviously, for milder cases, you can use artificial tears. We have immunomodulator drops like cyclosporin, Restasis, Zedra. We can also use prescription antibiotics or steroids, or oral antibiotics like doxycycline, which has both an anti-inflammatory and antibiotic effect. And as Melissa mentioned, some patients will use autologous serum eye drops. For those of you who aren't familiar with that, that's where they actually draw the patient's blood and spin it down to a serum and into a preservative-free eye drop that the patient can use themselves. And since it's made from their own blood, it's really going to be compatible with that patient. But I do want to caution you guys to beware the huge bag of eye drops. Every now and again, patients come in and they've been seen by multiple doctors and they have this gigantic bag of drops with everything under the sun that they're using. And actually, sometimes the preservatives and additional ingredients are really actually what's causing them to have kind of this chronic problem. So sometimes less is more, and it's not unusual for me to have them quit cold turkey and really just reintroduce a few things that are necessary to kind of get them the control that they need.
And I love when there are steroids in there and they just use them as artificial tears as needed.
Right. So beyond those types of treatments, there are also other things that can be used like punctal plug, Lacrosert, LipiFlow, Lefex, MyLiflow. There are moisture goggles and moisture sunglasses that can help protect from external environment, liposome spray, and homeopathic treatment. I will mention one thing about punctal plugs. I kind of like to use those with caution because a lot of times what happens is it's basically plugging the drain. And so sometimes when you're expressing these glands, all these inflammatory factors are just kind of sitting on the eye and they're not really getting drained very well. So they can be really helpful for some patients, but in others, if aqueous deficiency is not really their problem, it might not be the best option. And so then, of course, we come to scleral lenses, which we have a photo of there. We do think that there is a place for scleral lenses in dry eye treatment, particularly, I think, for chronic exposure, but we do want you to be mindful of the other things that you can do as well. Amniotic membranes are also becoming more popular for managing poorly healing corneas, as well as I think they're starting to look at it really for dry eye also, though I wouldn't say it's the most common use. And then we also talk to our patients about dietary changes, omega-3s, and environmental changes and lifestyle changes that can help them.
Thank you, Pam. Great presentation there. So moving on to a different patient case. This is a 50-year-old Caucasian female who was interested in wearing contact lenses for full-time wear, daily wear. She was previously diagnosed with Sjogren's syndrome, and she did have a history of dry mouth, ocular foreign body sensation, and a history of intermittent red eyes. Now in Sjogren's, there are many systemic symptoms, so not only dry eyes, but dry mouth, arthritis, dry skin. So just in general, if you're treating a patient for dry eye, if you're having them use drops, either artificial tears or prescription drops, please ask them the other questions if they have dry mouth and arthritis. You'll be amazed how much autoimmune disease you're going to pick up. So you can either run the lab work yourself or send them to a rheumatologist or primary care physician, but we're really looking for Sjogren's, we're looking for autoimmune disease, doing an ANA, anti-SSA, anti-SSV, rheumatoid factor, and I've been amazed since I've been asking my patients just how much autoimmune disease is picked up. Not always Sjogren's, sometimes lupus or rheumatoid arthritis, but when we're looking at the eyes, it's really the big picture we're looking at. In Sjogren's syndrome, we're very concerned about the risk of non-Hodgkin lymphoma. which occurs in 5 to 10% of primary Sjogren's patients. So the earlier the diagnosis, the better, so that patients can be treated systemically, and you can also help treat their eyes with scleral lenses. So back to the patient here. She wears glasses full time. She had a history of weekly replacement soft contact lens wear, but reported dry eyes with her contact lenses. She was reading in on the computer 8 to 10 hours a day. As I mentioned, she had a history of Sjogren's syndrome, was currently taking Plaquenil, and had a history of dry eye. When she presented, she was using Restasis, preservative-free artificial tears, and also Visine. So as Pam mentioned, it's really important to go over which specific drops patients are using. If there are any drops with preservatives, especially back, we want them to discontinue the drops because that can cause a lot of irritation and toxicity to the ocular surface. Here you can see entering vision was good with glasses, 20/20, 20/20 -2. She was able to see 20/20 in each eye. She had normal intraocular pressures. Looking at the eyelids and lashes, she did have meibomian gland dysfunction. In my Sjogren's patients, I always want to stain the conjunctiva with lissamine green. That's the LG there. So she did have both fluorescein and lissamine green staining on the conjunctiva. The right eye on the cornea had trace inferior staining. The left eye had 3+ staining at 3 and 6 o'clock. The posterior segment was normal. She had no signs of maculopathy. Again, she's on Plaquenil. Here you can visualize the lissamine green staining, and I do like to check that along with tear breakup time. You can check Schirmer's in these patients as well. On the left, you can see rapid tear breakup time and inferior corneal staining. So the Sjogren's Syndrome Foundation is a great resource for these patients. If you're interested, they do have pamphlets that I hand out to my patients about dry eye, about Sjogren's in general, and it's a really wonderful resource. An OCT of the macula and a 10-2 visual field were done. Both of those were normal. And we talked about quite a few things, continuing the Restasis, using preservative-free tears, not tears with preservatives, using ointment, drinking water. I'm a big fan of omega-3 fatty acids as well, and lifestyle changes, and also a big fan of moisture goggles for nighttime use, and eyelid hygiene, and warm compresses. So my approach when I talk to my patients, I give them a whole list of things to do. Some people like it differently. They like to give patients 1 or 2 things and then add more. But I find in these Sjogren's patients, it's really beneficial to fully treat everything and then they improve quickly. I also like adding in humidifiers for nighttime use and during the day as well at work if possible. So there are multiple manufacturers that have scleral multifocal lenses, which I have great fun with. I think it is so much fun. If you're interested, you can read up on it. And for this patient, I talked to her about different options, and we talked about using a multifocal design. So starting with the initial scleral lens fitting, she did obtain good vision, as you would expect. Even with glasses, she had good best corrected vision. The lenses ordered were a 16.4 diameter lens design. She came back and she said reading was better some days than others. She reported much improved comfort with the lenses, and she was in an aspheric multifocal design for both eyes. She was 20/20 and J2. There's a little over refraction on the left eye, and as you can see, both eyes had some peripheral blanching. And so new lenses were ordered, and I do this very often with an aspheric multifocal in the non-dominant, in the dominant eye, aspheric in the dominant eye, and then a center add progressive multifocal in the non-dominant eye. And sometimes I'll use a center near or center distance, depending on the patient's lifestyle and what they use. But I find that binocular vision does tend to improve that way with the aspheric on the dominant eye, and she reported clear distance and near vision, 20/15 +1, and J1 binocularly. And with the lens fit changes, flattening out the peripheral curves, she did have a very good fit, removing the lens. Her cornea and conjunctiva look great as well. So here you can just see some designs of the lenses, and it's great fun in these Sjogren's patients now to have the addition of Hydra-PEG with the scleral multifocal, and these are just such happy patients where they can wear scleral lenses all day long, and it really significantly improves their quality of life. So once again, I do thank you. We have a few minutes for questions, and we will be answering all questions by email if we don't get to your questions now. So it's all yours, Andrew.
Okay. Thank you guys so much. I'm going to start these quickly because I know we're short on time here. So first question, do you recommend lubricants or other medications on top of scleral lenses?
Sure, I'll take that. So that's a great one because it comes up all the time. So non-preserver or preservative-free artificial tears, yes, and I do like to recommend one that is not too viscous and not oil-based over a scleral lens, but yes, that's a great lubricant to just wash away debris all the time. Now with medicated drops, it is important not to use them with scleral lenses, so using prior to lens insertion and after lens removal. And the only tricky part there is if there are drops, say glaucoma medications that need to be used 3 or 4 times a day, then patients do need to remove their scleral lens, put in the drop, and then reapply it again.
Great. A couple questions on just the risks of scleral lenses in regards to, say, a normal corneate patient.
Yeah, certainly. So there is a lot that we don't know, and we definitely acknowledge that. Probably one of the hot topics that come up is regarding, potential hypoxia. Are we limiting oxygen to a normal cornea where maybe they don't necessarily have to wear the scleral lens? Is there any compression of the conjunctiva over time? Like, is having this larger lens that sits on the surface causing any long-term problems? There's a question about eye pressure. We don't know. Even just bathing a cornea in our saline that we're using, we know we haven't had immediate issues, but again, long term, we're not sure about whether or not there will be any problems. So again, this is why the conversation about risk versus benefit comes up quite a bit. And I'm not really sure, Melissa, if you had any other thoughts on that.
Right. So this is something I do talk to my patients, those with high refractive error, those with astigmatism, those with dry eye, those who have failed other lens modalities, and especially athletes. So, scleral lenses can be a great option, but it is important, I think, to go over all the options. You don't have to spend a lot of time, but for example, going over corneal gas permeable and hybrid and soft toric and scleral lenses and seeing which is the best for that individual patient. For athletes, scleral lenses can be quite amazing because the lens doesn't fly off, dirt and dust and debris doesn't get under the lens. I had a patient yesterday who was saying, oh, this is so wonderful. I don't get dust in my eyes and I can chop onions and everything's great. But, there are just a lot of unknowns. I do agree with Pam. There are a lot of unknowns about scleral lenses, and there's a lot of research that needs to be done. And I think, some patients feel just comfortable with the modality. They think it's fine, and others prefer to be a little bit more cautious. So just explaining the risk and benefit ratio for normal corneas, I think, is helpful.
Well, thank you both so much. We did have some other questions. Like Dr. Barnett mentioned, if you didn't get yours answered, it will be answered via email in the next couple of days. We have another one of these webinars in a few more months here, so everyone please check your inboxes for the date on the next webinar, and please join us for that. Again, thank you everybody for coming. Thank you, doctors, for the lecture, and we'll see you guys next time.
Okay, thank you.
Thank you.